Hi there, thanks so much for viewing this video. We're very mindful that the audio on the workshop itself wasn't ideal. And for that reason, Rosie and I have re-recorded our sections. And we just wanted to use this opportunity to say hi and to thank you once again for your interest in this project.
Hi, hi again. And yes, as Jono said, we're re-recording the event, or rather, we're re-recording our bits of the event. And we're going to be sending this out to people with a feedback form. And we'd love it if you could fill that out just so that we can improve and also understand what you found interesting. Particularly interesting because of course the whole thing is really interesting. um yeah, so anyway, I'll hand back to Jono now.
Brilliant. So the video that follows will be a series of re-recordings that Rosie and I have done where we hope the audio is much better. And then we've also included the original recording for the panel discussion and then the group discussion at the end. We apologise in advance, the audio isn't perfect, but we felt that actually we couldn't do any better than repeat what people had already shared with us. And so we know that you might have to strain a little bit to hear in places, but we can promise it's worth the effort. Okay, on with the rest of the video. Good morning, everyone, and a very warm welcome to Worcester College here in Oxford. It's so lovely to see so many people both with us here in person today, but also joining us online. My name is Jono, and I'm a researcher based here at the University of Oxford. I'm involved in a number of different research projects, but one of the common themes that unites them all really is that they're concerned with improving health and social care services, particularly for groups of people that are all too often overlooked by researchers. I'll shortly hand over to my colleague Rosie, who will introduce herself and explain a little bit about the project. But before I do that, I just wanted to give you an overview of what today is going to involve. So I'm going to begin with some introductions about the project that Rosie will be discussing. And then Rosie and I will spend some time reflecting on the key findings from our focus groups. In the first part of the session, we'll be thinking about people's reflections on their past and present experiences. We'll then have a response from an expert panel, and we'll break for tea and coffee after that panel discussion has taken place. And then in the second half of the workshop, Rosie and I will very briefly share some findings which relate to people's reflections about the future, what they'd like to see change. And then the final part of the workshop will involve a bigger group discussion, both online and in person. And then we'll wrap up with some closing remarks and lunch for anyone who'd like to stay with us this afternoon here in Worcester College. Okay, so without further ado, I'll hand over to my colleague Rosie.
Hi, my name is Rosie and I'm a researcher, an advocate actually for care experience voices in education, the arts and social policy. And I'm really pleased to be here today. I know so many of you both in the room and online. So thank you for joining us to find out more about this fantastic project for older people with experience of care, i.e. 50 plus. Jono and I first met on a project led by Aoife O'Higgins, Care in the Time of COVID, in Oxford in May 2020. And we know what was going on then, don't we? At the time, we felt inspired to do a small piece of research to find out more systematically what people's experiences were, and at the same time acknowledge the historical importance of what was going on. Care in the Time of COVID explored the mental health and coping experiences of over 200 care experienced adults during the UK's first lockdown. Participants were invited to complete an online survey and share a diary, and these took a wide range of forms. It was important for me to have art in the project, and they sent in photos and poems and music videos. The findings from the project were summarised in an article which closed by arguing that the impact of being in care is felt across people's lives. The legacy of being in care does not end at the age of 25 years, nor should the support that is available to people with care experience. And this is where our current project stems from and what today's workshop is all about. Interestingly, at the beginning of lockdown in May 2020, researchers at UCL had been working on a project that tracked more than 350,000 people using official government data between 1971 and 2013. They found that the likelihood of dying earlier among those who had been in care increased over time, unlike the general population, which experienced a decline. The majority of premature deaths were attributed to causes such as self-harm, accidents, or were related to mental health or were related to mental illness. And that's something that many in the care experience community already knew. In late 2021, Sophia Alexander Hall, who now works for The Big Issue, published an article in the Byline Times. In it, she discussed how care experienced people face higher rates of adverse childhood experiences, ACEs, which can shorten life expectancy by up to 20 years and increase the risk of serious long-term illnesses, helping explain the higher rates of early death in the UK. But there is a worrying gap in research on care and health outcomes, as Lisa, who's here today, hi Lisa, and welcome, tells us. We don't know these answers, and that is because no one's ever asked. Other than to highlight poor outcomes, statistics such as the involvement with criminal justice, mental health, and homelessness, there really is a gaping hole in research when it comes to this topic. It's like the concern and care that researchers have around children in care vanishes once those children get to 18. And part of our story continued in 2024. Anne Livingstone from the National Aged and Community Care Roundtable for Forgotten Australians contacted us and asked if we'd give a talk about our article, Care in the Time of COVID. She was interested in older, much older care experienced people, but there weren't that many. I think it was about 5. Whilst preparing for that presentation, we discovered that a research group in Australia was starting a project building a best practice model to advance healthy aging for care leavers entering the aged care system. There had already been a growing awareness of the health concerns of older care experienced people for some years. In Australia, though, not here, although care experienced people have been aware and have been speaking about these concerns for some years. And this project will be the first in the UK to start changing that. Following on from the presentation, Jono and I began discussions about a project with older care experienced people. I'll now hand over to Jono to say a bit more.
Thanks, Rosie. I hope it's evident from what Rosie has shared that this project has been the culmination of hundreds of individual and collective conversations over a series of years. And we also owe Lisa another really great debt of thanks because she's highlighted the importance of actually talking to care experienced people. This is something that's really powerfully conveyed on this quote. And that's just what we set out to do. So Rosie and I reached out to more than 900 community groups across England, and we received over 60 expressions of interest from people with care experience. And from those expressions of interest, we were able to hold 5 focus groups with a total of 29 older care leavers. This slide just gives you an overview of some of the participants' details. So everyone had to be older than 50 years, and our youngest participant was 50, and our eldest was in his late 80s with an average age of 66. 22 of our participants identified as women, 6 as men, and 1 participant as non-binary. The ethnicity of our group was predominantly white, but we also had representation of those with a mixed ethnicity, as well as Black and Asian Britons. Rosie and I worked really hard to try and capture the views and experiences of people from across England. So although a majority of our participants were based in the southeast, we were able to include representation from all of the regions in the country. Participants also completed a very short survey before joining the focus group, and this showed that people's health, as they self-rated it, varied quite considerably from a handful of people describing it as very bad to bad, through to people describing it as fair, as well as a number of people who felt that their health was good or very good. And I think this is something that we need to bear in mind, that people came to the group with a whole range of different health experiences as well. Finally, participants were asked to disclose a little bit about their upbringing and where they had been cared for while in the care of the local authority. As you can see on this slide, the majority of people spent part of their childhood in a residential children's home. People also described foster care placements, kinship care, being cared for in boarding school or approved schools, as well as one person mentioned an assessment centre. I think something that's also really important that came out a lot in the focus groups was the instability of people's experiences of care. Often people moved from a placement in a residential children's home through to one or two or three or a dozen more foster care placements, sometimes then returning back to a children's home or living with family. So people's experiences were incredibly varied, but instability was one of the sort of overriding themes. I'll now hand back to Rosie, who's just going to explain a little bit about the aims of the project and some of the really key findings that we observed.
So the aim of this project was to discover how older care experienced people's health and well-being can be supported as they grow older. The lifelong impact of care for many isn't something that ends when they leave the system, as was mentioned earlier in our article. It's something that continues to shape who they are, how they relate to others, and even how they see themselves. One of the key messages was the experience doesn't end at 18. And I don't think anybody in this room doesn't already know that. Our focus group participants described some strikingly different experiences. We heard about abusive childhoods, that mental health torture, the physicality of abuse left me battling to keep well and ensuring that I kept well. But on a long-term basis, it's had various impacts that I don't think even now are fully understood by doctors. That was what one of the participants said. We also heard about positive experiences of care. Quote, I also look at the care experience and think, I've got so much out of it in terms of loyalty, friendship. It's massively impacted my life. I think it impacts everybody because we're unique people. We go through an experience that 0.1 of the population will never know about. We also learnt how missing family medical history can also create risks. One participant shared that her child had died during childbirth because of an unknown medical history. And another example included not knowing that a condition was genetic. Quote, I have a condition which I didn't understand until I'd had my first child, and it was clear that they also had this condition. Later, we'll hear of ways the medical profession could improve this for care leavers. A fair number of participants found questions about family history difficult when going for medical care. Quote, every time I go to the doctors, without fail, someone asks me, does it run in my family? I'm sick of being asked that question. These accounts highlight how experiences of care can shape lifelong health through the lasting effects of abuse, the strengths gained from positive care, and the risks created by missing family medical history. We heard how for some, abuse in childhood can have a lifelong emotional and psychological impact. And I don't think anyone here will be surprised to hear that. Participants spoke about feeling differently. One said, I feel quite abnormal and I don't fit in society. Another shared that I think very differently, I act very differently. Feeling like an outsider was also mentioned. Quote, even in ordinary, everyday chit-chat, people talk about their parents. They talk about families. They talk about so many things that make me feel isolated from them and kind of the outsider on the fringe of the group. Some participants described a sense of endurance, a survival strength that became part of who they are. You're always left, but I think that gave me a superpower that drove me to be a very positive person. You can hear the strength in those words. The very act of surviving care and finding meaning afterward was an achievement. We also heard how the legacy of care is not just emotional, it lives in the body. Many describe the physical consequences of trauma. Quote, I believe it's from the uncertainty and the constant hypervigilance and having to be aware of where the abusers are for a start and not knowing where you're going to be within the next 5 minutes, let alone, the next 5 days. Yeah, I think they're linked. Some participants spoke of chronic illness, IBS, addiction, cancer, self-medication through smoking or alcohol. Some were, quote, expecting to die young. We heard about the connection between people's childhood and their health today. Quote, all the health problems I have now are actually related to my childhood. One of my fears is that I won't be able to live independently. We also heard how sometimes participants weren't believed. Quote, as a child, I was ill, but this was diagnosed as psychosomatic. Eventually, I was diagnosed with a brain tumor, and I've since found research that links it to childhood trauma. Though the legacy of care lasts a lifetime, participants describe it changing over time. Talking about it may become easier, and some say the experience made them stronger or more positive. Quote, the care thing will always be at the back of our minds. It will always be there, but it's how you manage it and how you look upon it. And that's not because care was good, but because surviving it built resilience. And we heard participants' attitudes toward getting older. Participants also shared how the psychological scars from childhood institutionalization shaped their fears, coping mechanisms, and attitudes toward aging and care. For example, one person called it her absolute worst nightmare and said she would rather die than submit to residential care. Another person explained that they would rather collapse under a bus than end up in a care home. One person described how, quote, I discharged myself from hospital. I struggled to be in an environment that is contained and around others. For many with care experience, growing older brings a new layer of reflection. Aging can trigger memories of institutional care and raise fears about dependence, control, or being looked after again. These reactions show how past experiences of powerlessness and containment translate into current health-related avoidance, such as refusing care, leaving hospital early, or living with chronic stress and fear of dependence that affect their well-being and engagement with health services. There are also conversations and signs of resilience and adaptation. Some participants found comfort in the idea of support if they could retain agency and control over their lives, saying, if I was able to make choices and check things out, that might be something I'd feel a bit better about. One person presented a unique view, suggesting that after a lifetime of feeling alone and having to, quote, take care of everything all the time, she might actually quite enjoy handing over responsibility and resting in old age. The legacy of being in care can shape lifelong patterns of trust, autonomy, and health behaviour. Later life health and well-being are inseparable from their early institutional experiences, affecting both their mental and physical health outcomes and their relationship to health systems. Participants explained that their childhoods taught them to be fiercely independent. The upbringing I had made us totally independent. You weren't allowed to make close friends. You were absolutely on your own. Somebody else said, you learn to be independent and to negotiate really complex situations by being independent and quiet. But there was also a cost to that independence. People shared that this wish to remain independent continued even when very unwell. Quote, I think sometimes we're too independent. Sometimes I won't go and seek help because I don't want to be not heard. So I will sort myself out and I don't need your help. Thank you very much. Many participants expressed both pride in self-reliance and anxiety about what would happen if they could no longer manage alone. Quote, to prove ourselves, even if just to ourselves, but I think it comes at a cost. It definitely caught up with me. Participants described how their hard-won independence could veer into what one person called destructive independence, leading them to reject help and push themselves to cope alone, even at personal cost. Before passing back to Jono, I just wanted to sum up some of my key takeaways. We've seen that care experience leaves lasting emotional, physical, and psychological effects that extend well beyond childhood, shaping identity, relationships, and health throughout life. Many participants described how early abuse, trauma, and lack of family medical history could contribute to chronic illness, mistrust of doctors, and feelings of isolation. As people age, fears of returning to institutional care, struggles with dependence, and extreme self-reliance reflect deep-seated survival habits formed in childhood. Yet, alongside pain and endurance, participants also expressed resilience, transforming survival into strength and seeking autonomy and dignity in later life.
Thanks, Rosie. Before turning to our panelists, I'd like to raise two themes that people shared with us in the focus groups. The first of these relates to stigma and really builds upon some of the destructive independence that Rosie discussed a moment ago. The second concerns people's experiences of accessing health and social care. First, then, stigma. Many people talked about the stigma that they lived with as a result of having been brought up in care. And often this stigma led people to silence their experience. People described a lifelong pressure to conceal their care experience because they feared either being blamed or pitied. One participant explained, "I chose not to tell people I was brought up in care, as there was a stigma and judgments made about you, and this was often seen as your fault, even many years later as an adult." Another aspect of stigma was masking, and many people described how they'd learnt to present a confident exterior and tried very hard to fit in. Someone explained, "No one would ever think I'm anxious, but it's a brilliant act." Someone else provided a really clear picture when they explained, "It's a bit like stars in your eyes. Tonight I'm going to be ... And this masking behavior was often something that people used within a professional context because they were concerned that disclosing their care experience, even when really relevant to the jobs that they were doing as adults, could threaten their credibility. One person explained, "In a lot of my work, I hid who I was just so I could step out and be part of society." The stigma associated with having been brought up in care and the associated masking came at a real cost, however. People talked about how they internalized blame, guilt, and shame. Someone described how, "I've put a mask on my face. What people see is very different to what I feel inside." Masking behavior could also have very real healthcare consequences. Someone explained, "I've put what I would call a mask on my face, so what people might see out there is very different to what I'm feeling in here. I've always felt that I'm to blame, so therefore I must take that blame, and I've hidden hurt, and that's created health problems." Someone else shared that the thought of letting the mask slip and being open and honest with people, sometimes in a therapeutic setting, felt really scary. Someone explained, "I worry I'll crash if that box referring to a childhood spent in care, is opened any further." While many participants talked about silencing their experiences and wearing a mask for much of their life, it's also really important to acknowledge that people did also describe disclosing their care experience in particular circumstances. People were very clear that disclosure was often reserved for those who'd earned their trust. One person explained how they befriended someone through a local community group, and it was only after knowing them for 3 years that they finally shared a little bit of their own history in care. Within the focus groups, it was really special to see people open up. And often people were very explicit about this being a result of the fact they were speaking to other care experienced people. One person said, quote, "Talking to all you people today, I know that you get me. It's easier to talk." Someone else who was a member of the Old Quorum Association, a group for people who spent part of their time in the care of the Foundling Hospital, described the association as being like a family group. And they found this really important, describing it as an amazing therapeutic tool in which they were able to share experiences in a way that felt safe. It's also really important to acknowledge that safe relationships with counsellors also enabled some people to share their experiences, and in doing so, to really benefit. One person described meeting with a counsellor, and they were really taken aback when the person explained, "I've got a lot of paperwork," but they were going to put that to one side just to understand why that person had come to see them. And this person was hugely grateful because this went on for more than 4 weeks, during which time they began to open up about their care experience. The second theme that I'd like to turn to concerned people's experiences with healthcare professionals. Now, some of these experiences are likely to have occurred to people irrespective of their care background. Waiting lists, for example, were commonplace. One of our participants had been waiting nearly 3 years to have epidural injections, and they described how they'd been put on a waiting list for a waiting list. Someone else put it very starkly by pointing out that the 18-month waiting list for therapy could be fatal in some cases because such a long wait could cause people to die before they got to the end of the waiting list. Long waiting lists also led some people to pay for support. Someone explained, "I did have individual therapy myself, but it cost me a fortune." Another common theme was that support was often short-term and not sustained. One person described how they felt as if they were just going in and out of different NHS services. A related theme was a lack of follow-up support, despite being promised this. So one person explained, "Once we got through that initial problem, I was back home and everything went away. Nobody seemed to bother to follow up." Someone else described going into hospital for a pre-arranged operation, and when it came to being discharged, they'd been promised support from the community nursing team, support that never materialized, and as a result, their spouse had to look after them. While the experiences I've just discussed could be true of anyone, people also described experiences that were specific to having been brought up in care. Lots of people talked about an insensitivity to care experiences. One person explained that doctors simply don't appreciate the impact that a childhood spent in care can have on people. Someone else talked about the forms and the bureaucracy that an experience with their doctor involved. They pointed out that it's how it's presented. A tick box headed family history didn't include them, and they felt very strongly that these forms needed to be reframed so that they could feel more included and part of society. Rosie's also flagged up the issue of not knowing a great deal about your family medical history. And someone put this really powerfully when they explained, "I'm sick of being asked that question and saying the same answer over and over again. I don't know, I haven't, I'm not in contact with them." And people felt exasperated that their files didn't reflect the fact that they didn't have any knowledge of their family medical history. And they found it really upsetting to have to tell people this over and over and over again. A lot of people explained that because of experiences in childhood, they had become very distrustful of those in positions of authority. One person explained that she would never ever be involved with the NHS with any mental health issues because of a lack of trust. And she explained that this was because she was worried about being described as what she called a bit of a loony and subsequently sectioned. This person went to the lengths of actually making up a pseudonym when they accessed certain services because they were fearful of what might happen if they shared their real name. A lack of trust also caused some people to be worried about the future. Someone described how they'd really like to receive support in their own home, but trust was a really big issue and meant that they may be unwilling to access support that they were entitled to. As well as describing a number of really difficult encounters with health and social care professionals, I think it's really important to also acknowledge the really positive experiences that people described. What was striking is that participants valued professionals who listened and acknowledged their concerns. One person described a doctor who was really kind and assured them that the numerous physical conditions they had were very real and that she wasn't a hypochondriac and that she deserved to access support. Another person described being in hospital at the peak of the pandemic, and they had a really profound moment of validation when, as an inpatient, a doctor acknowledged their health concerns. This person, who said that they weren't at all religious, described it as feeling as if a hand from God had touched their head, because up until that point, no one was listening to them. Participants also described some really positive examples of interacting with mental health professionals. And this support tended to be characterized by sensitive, sustained support that focused on deeper issues beyond the symptoms with which people were presenting. One participant who had experience of being supported by a number of different mental health professionals described one particular counsellor as a completely different ballgame. They described this person as incredibly astute, kind, and professional. And all of this culminated in making them feel very safe. And so while therapy was really hard, it was something that they described as an amazing experience. One of our Black participants described proactively seeking out a Black therapist who could specialize in supporting those who'd experienced trauma. This person was able to work with a professional they described as really empathetic and understanding. And they contrasted this really positive experience with some of their earlier encounters with mental health workers. Finally, I think it's really important to highlight that participants really valued community and holistic approaches to health. One person described their GP as being quite progressive because they favoured an integrative approach rather than what they described as simply dealing out pills. They gave as an example the fact that their surgery ran a creative arts program, which they accessed and found brilliant. Another person accessed support through a volunteer cancer group, which they described as brilliant. She particularly valued the buddying system, whereby a cancer survivor accompanied them to appointments, something that they described as invaluable. What was really striking when listening to this person's experience was how the little things, such as having someone to hold your hand when you were being given some news by a doctor, made such a difference and really helped them to feel supported during what was a really difficult process. The slides that Rosie and I have just shared are a tiny fraction of the incredible things that people shared with us. And at this point, I'm delighted to invite three panelists to reflect on what we've been talking about and to share their perspectives with us as a group.
Right, so it gives me great pleasure to introduce Lisa, Terry and Jim, and you're in the right order in my list. So the first of our panelists is Lisa. Lisa is an acclaimed author, researcher, trainer and consultant. Lisa has over 35 years of experience working across the public sector, including social workers, educators, and the probation service. And Lisa has really carved out a niche in supporting organisations to create systematic change in how they work with individuals living with the legacy of trauma. Now, Lisa's impactful work has taken her around the globe, including to the US, Australia, and parts of Asia. And if that wasn't enough, last year she was awarded her doctorate from the University of Oxford. And her research explored how care experienced adults experience school exclusion. So please give me a very warm welcome to Lisa. So our second speaker is Terry. Now, Terry has been a really dedicated advocate for care leavers. He's the co-founder of a really important website called Care Leavers Local Offer, which is an invaluable resource that compares the support by local authorities across key areas like health, education, and employment, and encourages councils to continually improve. Terry's also a trustee of NIAS, a national charity committed to supporting children and young people and adults in vulnerable situations. And crucially, Terry's been a driving force behind a national campaign to get councils to acknowledge care experience as a protected characteristic. And to date, thanks to these efforts, more than 120 councils across England, Scotland, and Wales have committed to this. This means that more than 25 million people now live in an area where local government is committed to considering care experience, and he's not stopping there. So please, can we give a very warm welcome? And then our final speaker is Jim. Jim is the chair of the Care Leavers Association. The CLA, as I'll call it, is committed to ensuring that people have a good life in care and a good life after care. And under Jim's leadership, the association is pursuing three strategic aims: improving the lives of care leavers, increasing knowledge about the care leaver experience, and amplifying the care leaver voice to improve outcomes, policy, and practice. And Jim has been involved in a huge range of initiatives, supporting individuals from navigating the complex process of accessing their care records, as well as conducting research on behalf of the Department of Health, which has been looking at the health needs of care leavers. So please could we give Jim a very good. So Lisa, I'd love to start with you. I suppose my first question is that getting older brings with it a number of health challenges for all people. And I wondered, what do you think is particular about these challenges and how they might intersect with people's experiences of having to be brought up in care?
That's such a big question, particularly because I'm navigating that myself currently and observing my own kind of responses to, I mean, first of all, can I just say, it's amazing to be here for two reasons. One, because I'm back from the brink of death, and two, because you're doing this research, which I just think is amazing, to even gather these voices and to explore health and well-being and the impact of aging into another system, because that's kind of what we're talking about. Obviously, people will access systems potentially across the life course, but I think there's something very specific about considering aging into the system. But as someone now using a system, I personally experience what I'm going to term hospital rage, which only happens when I enter into the hospital, which I have to do once a week to go and get my life juice. And there's something about going back into a system that by definition is a treadmill. It just is. The art for practitioners working in that system is for it not to feel like a treadmill for the people using it, but that's exactly what it is. And I have a visceral reaction to being in a hospital and being part of a system. And so I'm a bit more detached from thinking more generally because I'm experiencing it on a very personal level. And so I'm still very much processing that impact. So there was nothing in the research that you highlighted that didn't make absolute sense to me. All of it resonated. All of it felt very relevant. And I recognised all of it.
Yeah, it's really helpful. what I'm going to do is go along the line, and I think what will naturally and organically emerge as a bit of a conversation. But I wanted Terry to come to you next and really to get a sense of what has the response been from local authorities, but also from government, when you've been going around the country making a really strong case for why care experience needs to be acknowledged in a way that all too often it isn't. What's been that response?
Well, it's still a matter, especially with the administration. But it's not necessarily a political thing. It's how the administration briefs the politicians. So, you know, across two different parties in government, we're getting the same responses. So a lot of it is a lack of understanding of that actually what it's going to achieve. So to be clear, what protected characteristics does is it gives voice to care experienced people wherever system and policy is designed. And the way it does that is it puts into legislation, when we get it, a mechanism for that voice to be heard. And if there's a mechanism, it then means that we can challenge it if it's not being actually done properly. Now, I'm not kind of naive to think that the current system of equality impact assessments is actually working great. But what I can say is when we get it into legislation and it's a mechanism, then at that point we need to revamp how the equality impact assessments are done. So when you're doing an equality impact assessment, you have to think about who is going to be impacted around the service or the decision that you're going to make. So, and it is for care experienced people of all ages, there's absolutely no cut-off here. So when a service or policymaker makes decides how they're going to change it, so they have a legitimate aim of changing a policy or creating a policy or creating a service, they have to consult. They have to speak with the people who have the protected characteristics and see how they will be impacted. And that is the voice. That is how we get the voice. And what generally happens with care experienced people is it's generally social care and free corporate parenting that have that responsibility. But all the other agencies that have direct impact on us, they don't even know we exist in many cases. So what this will be is it will be the first time that these agencies and these policymakers actually hear and understand who we are. And when we talk about the impact that it's having at the moment, it's having huge impact on people that haven't heard who we are. Because when they understand and realise that we are 70% more likely to die prematurely than any other group, and we live 20 years less than everybody, they think, wow. And then they think about their own families, and they think, if this was my family, what would I do? So the mechanism that we're trying to put in there is this, it's an undercurrent in legislation to really draw out systemic change in every single part of the system. And from like my journey, I've actually realised that this is actually bigger than care experience. This is if you fix it or create a mechanism for the systemic change to be fixed for the most vulnerable group, then everybody benefits, because those same fixes happen for everybody. And that then means as well that you don't have to wave this flag and say, I'm care experienced, to basically get equitable equality. And so that just knocks the argument away of it being stigmatising to make care experience a protected characteristic, because you will literally, the system will be redesigned around you. And we are on the cusp of absolute global change with artificial intelligence and the way systems and stuff can all kind of come together. And this is like an example of how you can use legislation to create systemic change and just knock all the silos down. And that's what we're trying try and do.
Can I just add something? I know, Carrie, you're going to note that Carrie wants to speak on this.
Just that there's a bit of distortion, I think, for some people still.
Okay.
Only when men speak, so to me, that's.
Oh, yes.
I'm not sure there's anything we can do about it, but I think they're doing tech support with each other on.
Speak higher. The men have to just slightly raise the voice. But just before Jim is asked a question, could I just say that one of the things that you said was that the little things make a difference, and then you described a really big thing, right? Which I think is kind of what you're talking about. It's very tempting to think of it as a very little thing to have somebody in the community go with you to an appointment. But actually, you try and make that happen. That is a massive thing. And actually, the other thing that's really massive about that is relationships. Because what we're talking about here is what it is to experience the world from a place of relational poverty. And what you're doing is you're nudging people to think about their relational wealth and consider what it is to not have that. And in doing that, in considering what it is to not have that relational wealth, there's an opportunity to think, well, that's unbearable. The thought of not having that is so unbearable that I want to do something differently for people where they don't have that relational wealth. And that is a big thing. That's a very big thing.
And the only way you can get that is through hearing the voice of parents and people.
Yes.
Do not have the mechanism for that. That's what it does from the back.
Yeah. I think it's amazing. I've told you 100 times. I think it's an amazing thing to do. It opens up those conversations so powerfully. And I think I love that.
And I think it's so helpful to be reminded that actually the little things can be enormous. And that's a really helpful thing to do.
Can I just add that Carrie said, no, my hand was up by accident.
Okay. We were here for you, Carrie. We were here for you, Carrie. We really were.
But there's some wonderful comments on here. So we're going to, do
we need Jim first? Because look, poor Jim's on the end there with his male voice.
I know it's going to disappear, that thing.
Not much I can do about that.
I'll come to Jim and then perhaps Rosie, if you'd like to comments over here as well. So Jim, my question for you is that the Care Leaver Association does a huge amount for care leavers of all ages. And I wondered, thinking about the emails, the phone calls, the messages that you might get, the people who stop you at conferences, to what extent do you think there's a difference in age and the sorts of things that people bring to you? Do you feel there is something distinct about being someone that's over 50 and has been brought up in care? Or are those challenges very similar, do you think, irrespective of people's age?
They are very similar. I'm just going to say two things in response to that. Before I do, I just want to preface them by saying, in relation to this piece of research that Jono and Rosie and our colleagues have conducted, the role of the CLA was to promote this amongst our members and amongst other care leavers. And before we promote researchers, because we get asked this a lot, our key question, as Carrie will know, is do we trust these people to do this properly with our members and the care leavers? And I look around here today, and I know enough of you here to know that they've done it in the right way, because if they hadn't done it, we wouldn't be here. You would vote with your things. So I feel that the CLA's trust in what you've done has been vindicated, partly by the slides of it, but also by your presence here. But for me, that's fantastic from the word go. To answer your question, there's 2 points I'd make in relation to that. Yes, the experiences are common across the board. But there's two things in relation to age that I wanted to say, in relation to particularly your focus on 50 plus. The first is I was thinking, what the care experience people that we all share in common? Because our experiences are all very diverse, foster, residential, 1 year, 18 years, whatever. And what we share in common is being taken from our families and the family ties being broken. Now, if you think, I was trying to think of this in terms of knowledge and what we know and what we learn. And we learn about aging. If you're in a family, you will learn about aging from what happens to your parents, your grandparents, your aunts, your uncles. There's a whole wider family experience. So that by the time you get to, let's say, my age, early 60s, you know what aging looks like and the problems of aging because of what your forebears, one way of putting it, have already gone through. There's a sociology of knowledge within the family about aging. That's what people in the care system often don't have. They're isolated simply by the fact that they haven't got that family going ahead of them on the journey. I don't want to sound like Elton John, but it's a circle of life thing. The circle of life has been broken. So that knowledge that we acquire isn't there. And the logical outcome of that is that many care experienced people are far more reliant on the knowledge of their partners, if they've got them, and of professionals. They know things that you would normally assume people, they don't know things that you would assume people do know. That's the big, that's the first point I wanted to make. The second one is quite specific. Some people in this room will know this through very direct personal experience. People of roughly my age and above, so you're talking people in their 60s, 70s, and 80s. Many of them will have been in the big institutions when they were children. I was in one for several for a few years, and those institutions are now closed. So a lot of people in the health professions and in professions generally won't even know they existed. The effect of institutional care, whether it's a bunch of Roman Catholic nuns or whatever it is, how that impacts you in later life and how you feel about going back into institutions. A lot of people won't know about that. So in a sense, the big thing we have to do, I think, apart from all the other things that you're pointing out, is educational. It's educating professionals about the realities of the care experience. And both of those 2 points in particular.
Well, I don't know how to.
We'll just read it from
I
here.
didn't want to change the screen. So, but the one that I wanted to read out has disappeared.
Well, there's such a brilliant point from Jim. Haven't thought about the impact of not observing family ageing. That's one. Just while Rosie's having a look for the one that's scrolled away. Not knowing what you're going to look like when you get old has been put on there. Potential for huge impact.
So there's a comment here from Claire Fitzpatrick. I don't know if she can hear me or not.
Can you hear us, Claire? Can you hear Rosie?
Thank you for coming today. And she says, thank you, Rosie and Jono, for sharing such powerful findings. They are difficult to hear, and I'm not talking about the volume. I mean, I feel quite emotional listening to them, as there is much that is familiar, but I don't think I've seen them spelled out in this way in research findings before. There is a potential for huge impact here with this important work. Sorry, I've got this blue thing that keeps appearing.
People jumping sides.
Yeah.
Let's see what's next.
Sit here.
You want us to get out of the way now?
No, I don't need to know where you are. Sorry, I just don't know where the mouse has gone.
Be interested to know about any plans. Don't worry, that's fine.
Okay.
I think. Thank you, Claire. What else do we have up here?
While I'm
Such a brilliant point for Jim. You've already mentioned that, haven't you?
I think there's another reference to Jim's amazing points.
Jim, nail on head re-GPs, unfamiliarity with care in large institutions, especially relating to those run by nuns.
Yeah.
I think have absolutely, who's this up here? I can't have absolutely no idea what I'm going to look like when I am old. Okay, that's gone. John Paul, I think, are you in California? JP, I appreciate the conversation about relational, thank you, about relational wealth. Something as simple as just finding a ride to and from the hospital after having simple surgery has been very difficult.
Can I add something to that?
Yeah.
Because I am very relationally wealthy. I have so many friends and love around me. It's phenomenal. And but and it's something that I hadn't really thought about deeply because I'd always felt very alone. So I didn't have the family relational wealth. But when I got poorly, and I also, I suffered, like, came through so strongly in the research from never asking anyone for help. I mean, you want to see me now, I ask everyone for help all the time. Help me have my water, you know, help, I'm joking. But you know what I mean? I'm very comfortable with it now because I've had to learn how to ask for help, learn how to do all of that. And it really struck me, if I hadn't had people, if I hadn't had this network I've managed to create, I don't know how you do the cancer journey. You're at the hospital all the time. It's very unrelational. So you're a body to be, you know, take blood from and give medication to, and in much the same way, it's like a parallel universe going on that you didn't know existed until you're in it. And it's a little bit like that with care, isn't it? You know, the care experience, it's like this parallel universe that's going on with all these experiences that, unless there's an opportunity to listen to voice and to be heard and to express, people have no idea. And even when I'm working with lots of people who work with people with care experience, they don't actually know what it means, because to consider what it means is very confronting. So you're spot on, Jim, about it's an education issue. It really is.
Yeah, somebody, Teresa Williams. Hi, Teresa. She says, such a brilliant point from Jim. I confess I hadn't thought about the impact of not observing family ageing. Thanks for opening my eyes. Very good point.
Yeah.
And I think, I should say, I think it's quite important to stress, I think that applies to people who have all care journeys, because I'm particularly mindful of people who've been in foster care, which is obviously the dominant form now. But people often assume that the foster care is supposed to be more like a family, that those relationships will carry on. But we know that they don't. So that kind of cut off from family life, it applies in many cases even more in foster people who've been in foster care. They haven't got an association like the quorum all boys and girls and anything like that. So although some people in foster care will have, you know, good relationships with their former foster carers, many will be in exactly the same position as people from institutions. And that family network of forebears going ahead of you, it's still not there. It's exactly the same problem.
And those were in multiple foster placements.
Oh, yeah.
Intensive that.
And Zoe Baker mentions also when places ask for multiple emergency contacts. I, and I'm sure others here, will have had the experience of not being able to complete those fields and forms. I don't know if we included the comment about some of the people in the focus groups were talking about, this is later on, talking about ways that the health service could be improved. Some very, very simple, which we're sharing later on.
I had a follow-up question, which is, to what extent do you think there's a value in bringing people with care experience together? Do you think that that's something that would be constructive and helpful, or is that something that risks feeling forced and artificial?
It depends how it's done. I mean, we in the CLA, we've got a project at the minute, which is funded by the National Lottery. It's called Connected. It's bringing people, care leavers over the age of 25 together in various forums. And some of them engage best through writing, or some just through observing. So being in a Zoom conversation and not saying anything. Some want to be in forums like this. The value of it, I think, is that you get, firstly, for care leavers themselves talking to each other. It's a very different experience to dealing with these issues in isolation. It feels, I think somebody on there said about the quorum network, that it feels like you're part of the family, that you they understand each other in ways that other people won't. And I think in a health context, it could also be particularly valuable. For the reason I said that often people are doing this on their own. And as you said, and I think somebody said, one of the respondents, that they're almost preternaturally independent. They're used to dealing with things in isolation. And many of us very, very self-sufficient and good at this. But sharing your experience with people who've been through similar experiences, in a sense, it can be a form of healing in itself, as most of us know from our own experiences.
I think also, sorry, just very quickly, I think when you are over 50, that experience of not sharing your experience because of the stigma and the shame is very profound and quite different to, now you can join a group, you can online, there's all sorts of ways you can, we've even got people wondering about who aren't care experienced, who want to be care experienced. I mean, it's gone from one extreme.
Very true.
Yeah, it's gone from one extreme to the other, right? Whereas those of us over a certain age, the last thing on earth we would have wanted was anyone to know that, we'd been in care. And certainly being in employment and not sharing it. I myself started sharing very openly about it when I got past 40. So I think that's a very specific thing. So for different generations, it might have different meanings to come together and talk. It might be very meaningful if you are over a certain age to have done that. I think that's what this looks like.
Yeah, we did find that in the focus groups, didn't we? Some people had not spoken to other people about their experience of care, and they absolutely, I don't know if loved is the right word, but they really enjoyed being in the groups and meeting other people, because we know there's that connection that happens almost instantly. If you say, well, this happened to me or whatever, I grew up in care, there's an immediate understanding that you don't get with people that have not been in the system.
Terry, can I come to you? I think you were going to say.
Yeah, it's interesting that you say love, because that's exactly how I see it. You could be like in a war zone, you could be having bombs dropping everywhere, and you could have your cortisol and your stress levels raising, but then you've got love and you've got family and you've got community, and then it reduces it. But for care experienced people, if you haven't got love and you haven't got family, then that cortisol just increases, and it's that causes the disease that makes it so that we're 70% likely to die and live 20 years less. So it's fundamental that we understand how this works with our bodies, and really love is the cure.
Well, somebody's just put in here, Teresa, I think, was putting that, actually it's disappeared now, but that the Recenter are looking at relational wealth and relational stability. And I guess that's love, isn't it? We're thinking about relational wealth and what that looks like. And if you for whatever reason, the thing about experiencing those early childhood experiences is that it impacts your adulthood, which you were talking about, in terms of where you live. Do you move around a lot because you're used to moving around? How do you embed in your community? What sort of relationships do you end up having? All of those things that then shape and form whether you can, access relational wealth. And, I think that's the key that people don't understand, and the key that we need to make a difference with.
I would like us to have an opportunity to enact some relational wealth by getting some tea and coffee.
I love that, Jono.
Thank you.
I love that.
It would be wonderful if we could be back and ready, raring to go at 5 to 12, so 10 minutes or so.
Wow.
Please feel free to bring coffee and cakes to the table. Thank you to.
Hello again, it's Jono here. Thanks so much for listening to the panel discussion. You're very welcome to pause the video and make yourself a cup of tea and/or get yourself a slice of cake. The rest of the workshop will continue very shortly. Welcome back. The second half of our workshop will predominantly be devoted to having a bigger group discussion. But to kick things off, Rosie and I just wanted to share some of the things that our focus group participants said that they hoped would change as a result of this project. I'll hand over to Rosie to kick us off.
So the magic wand question, for those of you who don't know about the magic wand, this is something that is often used in therapy where you're asked to imagine if you had a magic wand and you could change this or change that, how would you use it? And we asked people to think about the future and to imagine that they had a magic wand. Participants' concerns were for children in care today, which I don't think anybody here would be surprised to hear. For example, quote, there needs to be more change and support, not only for us adults, but the ones who are going to be us one day. People felt strongly that, quote, care children should have therapy from the second their foot hits the hallway floor of the care home. It's a traumatic experience. Give care children therapy so they don't need it as an adult. Another participant said, quote, I'm really proud to be part of this project to help younger people in this research, end of quote. A chance to share intergenerational knowledge for the younger generation. As the focus groups went on, we got better at asking people to think about how their magic wands could be used to support older care leavers, and participants got better at thinking about themselves. The thing that came out loud and clear was, quote, therapy, good therapy, tailor-made to that person therapy, tailored mental health care support, and, quote, access to psychological support without having to leap through barriers. So I think we're all agreed that therapy would be a really useful thing for people when they first enter the care system. Finally, people talked about the importance of receiving long-term support. One person powerfully articulated this point and said, social services takes over parental responsibility when a child goes into care. And parental responsibility is a lifelong thing. My daughter's 28. She still comes home if anything goes wrong. That's my duty as a loving parent. I think social services should have the same duty of care. I thought they did. Far more eloquently than we had expressed ourselves, people came back to the point that the impact of care is lifelong, and so too should be the support that the state provides. I'll hand back to Jono now, who's going to mention two other types of wishes before we turn to you and ask for your thoughts.
Thanks, Rosie. One theme that came out really strongly in our focus groups was the importance of recognition. One person explained, quote, I don't think we even come into the realm of consciousness with policymakers, close quote. Another person explained that, quote, the words that came to me were, we matter. I kind of feel like we've survived the care system. I think there's a lot of lived experience within that, and that experience really matters. Someone else wanted policymakers and practitioners to face up to when they had let people down. They explained that one thing I would love to see is people to own their failure towards us. We have been failed, let down. It has had such a massive impact on our lives. I really want that recognition. And another focus group participant said something similar. They felt there was something actually very therapeutic about being recognized and acknowledged. They said, if you're heard, it helps release that shame, those labels that are put upon you. Labels that we've heard earlier today could cause such lasting damage for people. Alongside recognition was a related wish that those with care experience be involved in the process of making policy, informing the decisions that would shape the lives of children in care today. Someone explained, I think one of the key things is to have more care experienced people involved in making policy, so that policy can actually reflect what it's like, so we can improve conditions and services in the future. Another focus group participant said something very similar and stressed that their experience has huge value that would be of real help to the system to improve services and positively change things for the better. As we come towards the end of the workshop, Rosie and I would really like you to think about what you would use your magic wand for. So if you're with us in the room today, please could you turn to the people on your table and think through these 3 questions. The first is, if you had a magic wand, what would you like to see changed? You might use your wand for things that have already been mentioned, and if that's the case, we'd love to hear that. But we're also really interested to hear about other wishes that you might have. The second question is, what was the most important thing that you will take away from your focus group, if you took part in a focus group, and/or from today's workshop? And then finally, Rosie and I would be really interested to learn what your messages would be to researchers, policymakers, and then health and social care professionals. If you're joining us online, we'd really love to involve you in this discussion. We'll shortly put you into some breakout groups, and you're also very welcome to add your comments to the chat. And when we feed back, we'll make sure to read these out as well. You'll all have about 15 minutes, either on your tables or in the breakout rooms, to reflect on these 3 questions, and then we'll have time for a bit of a discussion, because we're really interested to hear what your thoughts are at this stage.
Okay, at this point in the workshop, there was lots of happy chatter in the background. And if you're watching online on sort of catch up, I'd really encourage you just to take a moment and think through the 3 questions on the slide a moment ago. And very shortly, the video will continue and we'll pick up from when we fed back as a group, starting with the people online.
We're going to go around here. Well, actually, we're starting with the online people. JP, wow. Okay. So do I need
Good morning.
Okay. Hi, JP. It's amazing that you're still awake.
It's okay. It's almost 6 o'clock. We'll be okay. Hi, Rosie. Hi, Jono. One of the things that we talked about is just kind of the lack of resource and the lack of time, and how very difficult it can be for people who are even, I think, very well-meaning to be able to provide kind of even the most basic or adequate of care, just because there's just not a lot of resources committed to getting that done. And it is something that I think that people are much concerned with. And I know it sounds basic and unimaginative, but it's a problem here in the United States as well. Oh, and by the way, I'm John Paul Horn. I'm an associate professor in youth development in California. That's who I am. So that's why I was here. So hi, everyone.
Hi, thank you.
Hello, John.
Somebody needs to leave. Louise Maple, thank you for coming. Sorry?
There's some hands raised.
Okay. Okay, so Lorette.
Yes, very briefly. I'm Lorette. I'm living in Berlin. Do you hear me? I'm from Berlin in Germany, and I'm so happy to see some faces and hear voices of a lot of people that we've been chatting along, and that's beautiful as the first thing. What I'm taking away from our group, what I never thought about was like talking about architectural stuff and like sensory experience and things to integrate, first of all, in care homes in general, but also like thinking about aging and how this affects our experiences in health. And one thing that we discussed, which is, it's not new, but I think it always we need to remind each other of it, is the way how data is created on us and on over care experience and used even in older age, and how we need to work on this, like to, I would say also in this way, to learn from health, how to write down what we see and experience without I don't know, without creating another hurtful experience, or without someone who will use it 10 years later and take it against us. And there was more.
Thank you. going to go over to the chat now. Okay, so Teresa, hi. She says, I'm dealing with Louise Maple, who has had to go. Our magic wand answer was that all professionals, stroke practitioners, would know, stroke understand if they were working with someone with care experience, would value what they say and would work relationally with them. Thank you. Dave, hello. She says, we talked a lot about having more love and kindness in the system towards all involved, social workers, care experienced people, foster carers, etc. We also considered what a decolonised approach to social care might look like, including more training and support, exploring more accurate histories and developing greater awareness of diverse narratives of experience of care. Thank you. Teresa, hello again. On what we would take away, Louise, a designated nurse, will keep up her work to ensure local politicians have care experienced people more front of mind and the importance of care experience as a protected characteristic. Me, this is Teresa as a researcher, thinking more about later life experiences. Thank you, Teresa. Okay, I think that's everybody from the line. So now we're coming into the room.
We're coming into the room, and it goes without saying, but if people online would like to add anything else, that would be wonderful. We'll keep an eye on the chat.
I will.
We've got lots of pairs of eyes in the room, all keeping an eye on the chat. Yeah. So if Rosie and I miss something, someone else will point that out to us. I'd love to start with the table in the front here. I get the sense that some people may have spent all of their time on question 1. We've got a group of anarchists in the corner who sort of went freestyle a bit. So rather than turning to the questions 1, 2, and 3, what were the sort of key things that you were discussing? What would you like to share with other people? What would you do with your wand or take away or tell people?
I'll just go through there. So we talked really important in terms of researchers who are basically doing research. They should be doing that with care experienced people, doing peer reviews, and when they apply for a piece of research, we need to be looking at, is that what care experienced people want? I thought that was important. And obviously trauma-informed training for all professionals, choices of the types of therapy that care experienced people have, because we felt that it's like CBT or nothing. Lifelong advocacy.
Shift from a deficit approach to a capability towards recognizing human rights and care experience.
I think lots of those themes were actually discussed in the focus group, but we weren't able to discuss today. That particularly that sense that it's CBT or nothing, and actually a lot of people had been through that process, had come out the other side, and actually felt broken by that process. And actually, it was only many years later, when they accessed the right sorts of support, that the lights suddenly turned on and things began to make a bit more sense. Brilliant. Let's take a look at that. I know you all did your own thing. So,
well, we had one on the, which was mine actually, was the basic education of health professionals about the care experience, and basic knowledge as part of the training.
I was going to say that then built on actually all professions that are working with people should have a basic knowledge and training on care experience. So teachers, nurses, dentists, social care, all the social care workers. We also talked about needing to recognise the impact of racism. So it's not enough to say the system is racist, but actually how does that impact on people kind of throughout the life course, and how does that intersect with care experience? And then we also kind of talked about the need for accessible information, so that people who have care experience can learn about what research is out there, what charity organisations are out there, what can they access and learn from, because at the minute it's all kind of spread out in different places, and especially as you get over 25, a lot of the time you hear, okay, you're not eligible anymore. So how do we make sure that information is easily and readily available?
You can't see it, but people behind you are nodding as you were speaking.
Can I just
Yeah.
here, because this relates to what Terry was saying on behalf of his table. This is Teresa Williams. I think that's Reece Centre. She's from the Reece Centre, isn't she? Yeah. She's saying, well, on messages for research, this is an important topic of inquiry, but needs to be done with and not to care experienced people, which is what you were just saying, Terry, and involve care experienced people from the outset in research design, execution, interpretation, and I don't think she means execution in that way, interpretation and dissemination.
And reviewing research proposals.
Pardon?
And we added in reviewing research proposals.
Yeah.
So funders, those who fund research should have care experienced people reading those proposals.
Absolutely, good
And
idea.
better that.
Yeah. What can we learn from care for older queers? On notes, okay. I love that idea room, folks. CP folks may have some very great ideas of what might be helpful for them in their lives. I'm not sure what idea that was, JP, but you can add that. Teresa again, messages for policy. Think more about the impact of policy change on care experienced people through analysis, but also direct voice. Also think about wider public education, including in school. The caring community concept should include the diversity category, CEP.
Oh, James.
And Anne Livingston, hello Anne. Wonderful forum this evening. Thank you, Rosie and Jono, for the invite. Great to be involved. Do you remember I mentioned her at the beginning of the presentation? And look forward to keeping the dialogue going. Globally, we need to continue to raise this agenda in the health, aged and community care systems. Little understanding is present about care leavers in general, which is what Terry, you were saying earlier on. And when they are aging and what they need is even less. Great work, thank you. Teresa, messages for social care professionals. Why just social care? It should be all. But for social care, help to prepare young people to be able to engage with other services, including how to ask for help, as Lisa beautifully demonstrated.
Rosie, shall we go, we'll intersperse the comments with the chats in the room. So shall I go to the table at the back? Anna, Terry, again.
So some of the points were very much sort of echo what others have said, and some of what. So a lot of the discourse has been around children in foster care, but not all of children are suited for foster care. Not all of them are in foster care. So there's a worry that we might be missing part of the discourse. There's concern about unqualified staff in homes and lack of multidisciplinary expertise. So there's maybe examples from Europe that we could look to potentially mitigate that, at least try to. There's an interesting bit of history that the children who are in care now come from very sort of difficult, toxic, perhaps violent circumstances. Whereas it used to be that at least some of the children who are in care were just simply born to unwed mothers, right? So those children would have very different needs and possibly trajectories and opinion that needs to be sort of kept in mind. Duty of care of the system kind of ends at 18 now, because while you're adult now, what would it look like if it went later? So sort of creation of safe spaces on the sort of longer term. Need to take this research to health professionals, mental health workers, but not just, so they have a better understanding of the needs and the impact of care in the longer term, so they need to be educated, which they probably do. And something as simple as having a marker on the health record, so that question about your family history, where it's a sensitive issue, it doesn't get repeatedly thrown into the person's face, where it's, it's difficult to manage. And it's not just a sort of sensitivity, consideration, communication, but also the issue of, different life expectancies and different health challenges. it's a sort of to sensitize the healthcare professional to sort of keep that at the forefront. The mind when they are caring for a person with care experience. And I miss stuff. I took a lot of notes. I miss stuff.
Rosie, are there any more?
Yes, the assessment's not working. But there's a message from Jamie Cran. Hi, Jamie.
We're moving around the slides now. Look at this. This is so fun. Right. I feel like it has been amazing having people online. But it's also blown my mind how complicated it can be. Let's stick to in the room for the time being, and we'll come back to online. The table at the back, back in the middle.
On a note taker, it's not very good at note taking.
That's fine. Any note takers could note take.
So in relation to question one, it definitely concurs with one of the tables, and it was talked about what was needed if you had one, which was a long-term advocacy for care for children to navigate and signpost life skills and the system after they need care or well before care. That was challenged by someone else around the table, which is clearly a brilliant challenge. Which, why is that even needed? If it's so good what we do, why is it needed? I suggested there's loss between people, and we need to make better use of the systems that are there rather than creating all loads of new systems, which is what people do to fix systems that aren't good enough. So that was a whole discussion around how you achieve long-term advocacy and navigation for people that are going to need care way beyond 25. And then the second one was something that I brought up in response, a bit of a reaction to the presentation, was that I think the bar for parental responsibility is way too high here. We're all saying all birth parents must be marvellous, and that I felt there was a language change from, in certain documents I read nowadays, from it being a parent to being actually a guardian or a carer, and therefore why would we expect the same parental bar of care to come from guardians or carers? How can you ever achieve the same as that? And I know it might go boom, but that was just a bit of let that settle a bit, because I just think maybe we're setting the bar too high. We can't recreate parental responsibility, but what's the best we could do? And our final conversation led on to, well, then what does success look like, which was posed by the group. And you can say we start at your lowest bar, that someone that's left care, success might look like just getting out of bed, to having some life skills, to having a job, to be able to sustain a residence, or maybe take up some work. And if the government were to change something, were to help with life advocacy skills and all the rest of it, what might their outcomes be in policy? How would they measure that? Because they always want bang for their buck. And in question two, what was the most important thing you got from today's group? Well, we didn't talk about this too much, but what we did talk about was it was good to bring things out to talk about them, just to talk about it. And that someone in the group mentioned that one of the most powerful things for them was the person that mentioned the inability to have a relational aspect to observe aging with your own family, and that's been a real powerful point. And then that led to me saying, well, one of the most powerful things that triggered in my mind was actually I still have zero understanding of what family is, let alone aging. And then question three, which we just touched on, is what would your message be to researchers, policymakers and health and social care professionals? And you mentioned very strongly that you felt that what are the rights, and we don't mean militant rights of people who've been cared for, but what are your rights to feel how you feel, whether that's very sad about your trauma and experience and not to have that completely dissolved and just get on with it. What rights do you have to have that respected? And that's very powerful on the table. We didn't explore it enough because we ran out of time. And then I wrote one on at the end just as we were closing, and I said I felt that health and social care professionals, particularly social care professionals, should really consider their redaction of care records. Yes, because massively so mine, massive problems. black, and I couldn't tell you. They gave me my care because they arrived by DPD. 5 box scores, mostly 90% reductive. And if you want someone about their health and well-being in older age, why send them a whole pile of records that some social care professional has sat and gone through for hours on end? I dread to think how many hours redacting records. So that gives you the information, but at the same time withholds it. And I would like strongly to put that to health and social care professionals and policy makers to say, you absolutely can't do this. You either keep the records or you don't bother. Thank you.
Finally, last, by no means least, let's take them. It's always an unenviable task to go the very last. There's a lot that's already been said, but is there anything you'd like to share at this point?
Sure, I don't know. So I'm Catherine Pope and I work in primary care. So I'm very honoured. This is one very small project in our research group about care. This work through my life. So I played a teacher and wrote notes about whatever I said. So we've got 7 lines. We've got 7 lines. So the first one was quicker access to care, and we think that one of the things that might also assist with that would be more screening, like a specialised screening that would allow you to do blood tests and things that would flag that you think up early, and that might address the earlier mortality, death rate, and some of the issues around long-term health problems. We need more money, and I pushed because I'm a teacher, and I was like, okay, but what would the money do? And what the money would do, it would allow in social care continuously better training, better pay so that the social workers do their job better and feel rewarded for it, fewer clients on a case list, and less box ticking. And then we can do all of that with CAMS, and I imagine if we did a longer conversation, we could just work through all the services. So more money for everybody to do those things better. Equip the police to deal with things better, mental health things that sometimes are linked to care experience. Convince care experience people that they will be listened to and that they can't. And therapy from the start to help them so that they will feel heard. Mentorship, ongoing mentorship and advocacy to really help people in the care system. Education for medics, and there were 2 people from primary care here, and I've already sent an email to the person that leads the training for GPs and said, why is this not in our curriculum? How can we get it in our curriculum here in Oxford? There's some fantastic work going on at Oxford Brookes University already, so we just need to get it out there. But we want people in the medical system to understand health impacts, the fact that you've got no knowledge of your family, the fact that you might not understand how to make your way through the system, and help you do that, and really good communication skills. And we made the point about dentistry last week as well, because it's so vulnerable having dental work, and that's a real problem. And then the last one relates to your reductive records thing, which was about lost records. And we have a query that we think records are kept for 50 years if you've been in foster care, but 70 years if you've been adopted. Why not just keep the records and have them available? So that's our 7 records.
Thank you so much.
Yeah, we need the volunteer.
Yeah, go for it.
I thought it was really interesting that stigma in records, mostly when people apply for their records, it's from children's social care, but you got your records from the health service, and there was just a litany of stigma within it. And it'd be nice if there was projects that actually looked at that and looked at it.
Dedicated professional help write notes in a non-stigmatizing way.
Any research stigma in records outside of children's social care.
Right.
And I don't think they are redacted. I don't think they're redacted. social care. Wellbeing.
Yeah.
Change that.
No, do therapists have their roles to your care?
Well, they do have to take out third party information. So if you know, if it's a record about you, you're allowed to give it, but if it says something about, you know, my uncle or something, then that's not being in it, that's just like information.
Brilliant.
Can I just
Yeah, Rosie.
read out the comment from Jamie Crabb? Thanks, Jamie. He's sent it to me. So opportunities for care experienced people from the earliest age to come together as community to feel mutual resonance, understanding and recognition together. Number 2, therapeutic life story work to be available stroke funded without condition or in terms of, or without being limited by age to care experienced people throughout the life course, particularly when accessing files. This could be in groups. 3, researchers ensure inbuilt into the process is community building that can continue beyond the research for mutual care and support. That was A. B, policy, walk in care experienced people's shoes, have care experienced people on your teams or professionals, begin always from acts of care, which is lovely.
Thanks, Rosie, and to everyone for contributing to that discussion, both here in the room and online. It's been so helpful to hear everyone's thoughts at this stage. It forced me to have what feels like an impossible task, which is to wrap everything up. But actually, I'm really fortunate because when we were putting this presentation together, one of our focus group participants said something that really struck a chord with me, and it's something that I've shared on this slide. And it's something that I'd really like to leave you with. This person was asked, like all of our focus group participants, what their message would be to other people. And they explained, and I'll quote them here, the most complex thing you'll have to do is make them listen, because I don't think they do. This research doesn't need to be on a dusty shelf. It needs to be listened to. It needs to be respected. We've not been respected throughout our lives for whatever reason, but your research needs to be respected because you are doing an incredible job of representing people that have so much knowledge and experience to help others and to help us. We need help still. I'm not saying we need massive amounts. My counsellor is my help, and I'm lucky. I consider myself really lucky. But just that bit, really. Listen and be respectful and do something about it. I wanted to close with this quote because Rosie and I feel very strongly that this isn't our research. This research belongs to everyone who's taken part and has helped us to think through these really complicated but important issues. And our message from today is that we would love to work with everyone who's interested in helping to improve the lives of older care experienced adults, because we feel very strongly that this research doesn't belong on a dusty shelf, but needs to be put in front of policymakers and practitioners up and down the country so that real meaningful change takes place. If this is something you'd be interested in contributing to, please don't hesitate to get in touch with Rosie and I. This is our final slide, and I think it's only right that we begin in the way that we started, which is to say thank you. First and foremost, we'd like to say thank you to our amazing focus group participants. They've made today possible in more ways than I think they'll ever fully understand. Second, I'd like to extend my thanks to Michelle Peters, who's my boss and who has supported this work. I'd also like to say a really big thank you to Anna Scott, who's been able to join us in person today, but has also been a really integral team member and has helped us to think through this research. Nia Roberts is a colleague who's also really helped us to think about doing a literature review, which is something that Rosie, Anna, and I will be working on in the coming weeks. Special mention should also be given to my departments, the Department for Population Health, whose funding has made this research possible. I'd also like to say a really big thank you to the events and catering team at Worcester College. I think people in these roles are often the unsung heroes of conferences and workshops like the one today, and they've done an amazing job. And then finally, I'd like to say an enormous thank you to everyone here, both in the room and online. Today's event has really exceeded all of my expectations, and that is entirely down to everyone's really active involvement and willingness to think through these really important but challenging issues. So thank you. I'll hand over to Rosie, who will extend her thanks and share one final reflection before finishing today's workshop.
Thanks, Jono. And I just want to add to that my thanks as well to everybody on the list, you know, the participants particularly, and everybody that came here today and that's online as well. And I know that many of you grew up in care of some sort, and I hope that you've enjoyed listening to some of the things that participants shared. Just to say, it's a very, very small part of what we actually learnt and heard about. And I say learnt because it was a learning situation for me, both being, you know, part of the project, but also listening to older people with experience of care. I had really been looking forward to doing this because I want to learn myself. I'm getting older. I am actually an elder now. We don't use the word pensioner, do we? And I did learn. I learned about myself through listening to the participants, particularly things to do with anxiety. I didn't realize how much it dominated my life. I'm really nervous doing something like this, but I know that bit's quite normal. But it's the, you know, anxiety when I'm about to go away, and I still get those weird feelings of, I don't know if I'm ever going to come back, which I think, you know, we can work out is because as a child, there were times when I didn't come back to wherever I was. So that sort of anxiety I can understand, but everyday anxiety I didn't realize. And it was listening to other participants, which meant that I learnt a bit more about myself and the way that I respond to things. Um, so, yeah, it's been a real learning curve for me. And what we're also going to do is we are going to share for those that couldn't make it today, and even those that could make it, we are going to re-record some of the worst bits of the sound, and we're going to share that with people, and we're going to ask for feedback, especially from the participants, because we want to know what they thought about this presentation. So that will be really interesting for us to learn even more. And I hope that, you know, that in the future they're involved in some sort of project again, you know, and helping to design it and yeah, working with us. Okay, so that's it from me. Have a really good journey home and take care and thank you. Bye bye.